I can go ahead and start. Okay. All right. So I'm doing AI in epilepsy. I'll be going next year to Vanderbilt for an epilepsy fellowship. So I just thought this would be an interesting topic that I initially was not very familiar with. So I thought it would be kind of interesting to chat about and discuss. So some learning objectives, discuss basic terms in AI, just so that whenever you're reviewing articles and are kind of, if you have any interest in looking things up, you have kind of more of a basic idea of what they're discussing and how these algorithms kind of work. So discussing AI as a tool in epilepsy and as it applies to current areas of interest included automated interpretation of EEGs, neuroimaging, epilepsy surgery, and potentially seizure forecasting. Discuss limitations of AI and possible pitfalls if used incorrectly. So AI is not a single methodology. It's a collection of techniques to solve a particular task. So its success stems from its ability to learn from its mistakes. And classical systems are based on statistics, have fixed knowledge. So they'll make the same mistakes repeatedly based on fixed rules. Interesting thing about AI algorithms is they learn from their mistakes, and knowledge database of an AI algorithm continues to increase with its experience. Okay, so a few possible applications of AI in epilepsy. So a few things I'll talk about are here on the left. So detection of interictal patterns in routine long-term EEGs, AI and neuroimaging, detecting epileptogenic zones, and then guiding decision-making for epilepsy surgery candidates, and then seizure forecasting and wearable devices. A few honorable mentions that I won't really go into are AI in identifying patients who are more likely to be resistant to anti-epileptic drugs, or what sort of regimen would lead to better seizure control in epilepsy syndromes, as well as kind of AI predicting risk of epileptogenicity of focal MRI lesions by routine EEGs. There are quite a few different applications that are being studied, so I just kind of focused on a few of them. AI draws on extensive data sets for clinical information. It can be less prone than humans to have biases that lead to inaccurate conclusions or likelihood of differential diagnosis. Increased speed and consistency of analysis of clinical imaging studies and other data and clinical decision making. So it can kind of usher in this era of personalized medicine. So I'll kind of start with some terminology, AI terminology. So AI is any technique that enables computers or machines to mimic human intelligence using logic, if-then rules, decision trees, and machine learning, including deep learning. So machine learning is a subset of AI, and it includes statistical techniques that enable machines to improve at tasks with experience. And then deep learning, which is kind of mostly what I'll be talking about, is a subset of machine learning comprised of algorithms that lets the software train itself to perform tasks using multi-layered neural networks to millions of data sets, essentially. So okay. So a kind of a artificial neural network, it amalgamates and processes many layers of information, each holding essential parameters that are extracted incrementally from trained data. The brain neuron network organization kind of inspired this concept. And you have these signals that travel from input to output after they kind of traverse and go through all the layers multiple times. So a deep neural network is an artificial neural network with multiple layers between kind of the input layers and the output layers. And you have various types of neural networks, and they share kind of all of the same kind of components. So neurons, synapses, weights and biases, and functions that kind of all work together and function like a brain neural network. So you can kind of compare deep learning to neuron firing patterns in the brain. A brain neuron, artificial neuron, in the deep learning network, they receive an input that's transformed into an output according to a set of rules that aid in its learning. Similarities between AI and neuronal function is that's often the reason why it's called an artificial neural network. So here's kind of, I have, this is from AI and neuroimaging study that I'll kind of go over a little bit later, but it's just kind of for explanation of how deep learning works, like the nervous tissue of an artificial neural network is made up of kind of many artificial neurons, and they're interconnected with each other in different layers. And each of these layers, you have input signals. They originate from the preceding layer, except for the first layer where you have like this initial like input data here. So like MRI or PET data. And you have output signals of each layer that are in turn the input signals of the next layer until you get to the final output response layer. So kind of see here. So identifying epileptogenic zones and like a temporal lobe, and then the layers in between the initial input layer and the final output layer, they're actually called hidden layers. And those are the ones that transform the input information that the next layer will use to make a certain prediction. And so the deep learning is kind of an extension of the artificial neural network concept and uses kind of many hidden layers, and essentially with the progress has been significantly based on increase in computing power that we've been able to use over the years. So the neural network has to be trained. So it has to be exposed to a large amount of input data with presence or absence of certain patterns. So for example, epileptogenic zones in the temporal lobe, so that it identifies that pattern later in new data. So that's kind of achieved by numerically weighting the input signals to the network to adjust the corresponding output signals. And then learning is achieved through a rule that adapts or changes the weights of the connections between the neurons in response to the input examples or in response to any sort of desired outputs. So the learning kind of is either supervised or unsupervised. So you have these data sets that so supervised learning, you have data sets that are presented to the neural network with a known output. And so by comparing the output to this data with a known or expected output, you kind of have a difference or error that you can calculate. So this is used to kind of feed back to the neural network and change the weights that tend to minimize the difference. But then you also have unsupervised learning. So you actually don't require any sort of like training, label training sets. And this kind of finds characteristics, correlations, regularities, or categories that can be established between the data presented and the inputs. So the advantages of this is it doesn't require it doesn't require any supervision to train the model, and it finds the hidden patterns in the data, and it allows it to perform more complex processing tasks compared to supervised learning. However, it can be less accurate results. And honestly, the best strategy, either supervised or unsupervised, really just depends on the purpose of like the research or the data or the experiment conditions. So here's, you kind of see like a supervised versus unsupervised scheme. And so this is from that same study that I'll kind of talk about a little bit later. It's deep learning and neuroimaging. So you have in A, the supervised learning scheme algorithm is provided with labeled data set. So you have kind of these examples that I discussed before. You have the controlled scans and then epilepsy scans. And then you have all of kind of these hidden layers and then kind of the output, and it kind of will tell you output pattern controls in epilepsy versus the unsupervised. You just kind of give them unlabeled data sets, and it's supposed in between all of those layers. It will figure out which ones are epilepsy and which ones are the controls or normal MRIs. So modeling and testing. So modeling trains a machine learning algorithm to make predictions from unseen data. So AI needs to be applied to a set of test data not used for training. So this sort of validation, it ensures models don't fit too closely together to the data used for training. And that prevents the artificial neural network from memorizing the responses to the inputs instead of kind of learning what results learning which would result in a non-reproducible model. So it means it's preventing it from not being generalizable. So alternative approaches to overcoming this sort of issue is called transfer learning. And so what that is you have these transferring of parameters from a different model that has been trained to do something else, but also has kind of large amounts of data to model for a different task that's sort of similar. So kind of consists of readjusting the final layers for use in a new problem. So the most widely used data set in the world currently is for medical images is ImageNet database, and there's also actually a pulmonary nodule database that's used for other imaging. A few other terms. So ground truth. So this is the actual nature of the problem. That's the target of machine learning model. And it's reflected by the relevant data sets associated with whatever case you have in question. So you also have a few different types of connections. So there's kind of feed forward propagation, and that is information that circulates in a single direction from the inputs of the artificial neurons to the final output layer of artificial neurons. And then you have feedback propagation outputs of the artificial neurons. They serve as inputs to peer units or side connections or previous layers. And then you have a convolutional neural network, and this is actually it's kind of neat. It's inspired by organization of an animal visual cortex, and it's designed to automatically and adaptively learn spatial hierarchies of features via kind of like this filter optimization. And so this convolutional neural network has kind of been the most widely used artificial neural network within neuroimaging based AI applications in neurology. And so like a visual cortex, the convolutional neural network displays connectivity patterns. So you have these like black box AI models that come to conclusions or decisions without explaining how they were reached. And the precise steps kind of really can't be explained, as the predictions come from parameters that are processed by machines and the machine-driven analysis maze that's not really direct product of human consciousness. Reinforcement learning is machine learning and training method that develops decision algorithms, and does that by rewarding desired behaviors and punishing undesired behaviors. And this kind of learns through the editing to make better decisions over time. And it can learn while failing to complete the task, and it derives basic rules guiding future predictions from the experience of performing the task. And it depends on the environmental interactions. So going into kind of more epilepsy, so AI-based automated seizure detection. So you have this, essentially we have a rapid growth of patient volume and EEGs. So it brings up the topic of automated seizure detection techniques from EEG signals. So the visual detection of epileptic seizures is a challenging task due to nonlinear, non-stationary nature of EEGs, electrical noise, other artifacts, and that's why I'm going for an epilepsy fellowship for 2 years. So limitations of something like this would include software that works on multiple people, just because you have so many different variables of different seizures. And then statistical methods also kind of sometimes can fail to generalize and accommodate. In real-time scenarios, there's multiple frequencies with different signals, and that impede analysis of patterns of underlying pattern without converting to non-stationary EEG signals. One way of kind of converting this from like non-stationary to stationary form, they break down this long trace of EEG signals and into kind of several smaller lengths in seconds. And these EEG epochs use short time Fourier transform or wavelength decomposition techniques. Essentially, they were just transferring kind of the data into a way kind of the computer could create the different layers and analyze it. And so they used EEG and magnetoencephalography analysis conducted to find final change in various features of the sort of signal. So the typical blocks in an AI-based diagnosis system involve EEG acquisition, and so then they would do this sort of pre-processing, and that would include getting rid of the 50 hertz noise, removing artifacts, and then have this machine learning or deep learning based approach. So the machine learning, you had this EEG analysis using time domain, frequency domain, or time and frequency based methods. And so these extracted features using the methods are selected and classified, and then the deep learning approach has a complete end-to-end structure that automatically just performs all of the feature extractions, and it all just kind of classifies it. So here's just kind of the classical machine learning approach versus just the deep learning approach. So AI can automate visual inspection by marking relevant signal segments in recorded EEGs into defined categories. So thinking discharge, ictal, interictal, artifacts versus some sort of normal background. So the goal for an AI or for the AI would be to give the physician an automatic list of like spikes, discharges, and seizures to review. And although these systems, the systems contribute to the diagnosis and early detection of epilepsy, they're only really a tool to assist in clinical decision making, and you know, they can't do all of the work for you. Further limitations include available data with high quality outcome labels, and then also AI and deep learning, they're only mathematical frameworks that can potentially answer a disease-related question through the application of the model architecture itself. And the performance of the AI models should be benchmarked against known clinical outcomes that provide sort of a target label for the AI prediction. So seizure versus no seizure, drug response versus no drug response, or on an EEG, depression versus no depression. Deep learning in neuroimaging, I thought this was very interesting. So essentially, there's no single diagnostic method to provide all information that you need for a characterization of patients with epilepsy. You know, typically using EEGs, anatomical MRIs, so those are the gold standard for diagnosing and identifying the epileptogenic zones. MRIs are sometimes discordant with the EEGs, and you have functional and metabolic imaging like PET and SPECT to sort of bridge this gap. And integrating several neuroimaging modalities can provide substantial improvements in localizing these epileptogenic zones. Correct localization of the epileptogenic zone can be challenging, and the non-invasive methods are often inconclusive, and even the invasive methods can also be inconclusive. So they usually require further investigation, further invasive diagnostics like intracranial EEG. Studies have shown that potential of artificial neural networks for automated detection of lesions in patients with epilepsy, specifically targeting detecting focal cortical dysplasias, which I will go into. So there was a kind of an interesting review of a few studies that had been performed, and here's a table kind of from this review article. And so the table summarized the study as they proposed deep learning models to kind of discriminate between individuals with epilepsy and healthy controls. And so they used T1, T2 images, FLAIR images, DWI, and multimodal MRI. And so you can kind of see here structural MRI, and then so the kind of modality that they used here, the sort of inputs, what they used for the information, T1 and FLAIR versus FLAIR, structural connectivity, T1 based features, DWI, and which sort of deep learning model, which I briefly just discussed at the very beginning. So the feed-forward neural network, then you have a convolutional neural network, and this is also convolutional neural network with kind of a fully connected neural network, and that just means each input node was connected to an output node as well. And so here you have the different populations. So 20 cases of FCD and then 28 controls. In this second study here, they used patients with temporal lobe epilepsy, 85 and then 56 healthy subjects, patients with JME, and then looking over kind of like how these AI algorithms performed, you can kind of see accuracy in diagnosis and accuracy in lateralization. And the ground truth that they used were either pathologically confirmed cases, whether or not that they could find this ground truth. So these AI programs did pretty well. So automatic FCD, so focal cortical dysplasia detection. So focal cortical dysplasias, they're the most common pathologies causing pharmacoresistant focal epilepsy. Resective neurosurgery actually yields high success rates, up to 70% of patients achieving seizure freedom, especially if the lesion is correctly identified and completely removed. Visual assessment of MRI doesn't actually pinpoint the focal cortical dysplasia in 30 to 50% of cases, and up to half of all patients with focal cortical dysplasias are not amenable to epilepsy surgeries. So computational approaches to focal cortical dysplasia detection is actively being researched. It does have its challenges. So imaging data needs to be organized into structured, well-annotated data sets and combined with other clinical information like the histopathology, the subtypes, and neuroimaging characteristics. And model prediction requires technically correct evaluation and adequate metrics that are actually understandable and usable for clinicians. So post-op seizure freedom is highly dependent on pre-surgical identification of a lesion on MRI, accurate assessment of the lesion extent, lesion location, and complete resection of the lesion, and what sort of subtype it actually is. So actually, notably, the favorable long-term post-op seizure outcome, it decreases to about 11% for people who have extratemporal epilepsy who are MRI negative. Conventional examples, so like voxel-based morphometry use statistical methods to find areas of the brain that differ from normal controls. So with the increasing capability of AI through machine learning and deep learning, new approaches based on artificial neural networks have emerged. And so it's really influenced the field of automatic FCD detection in MRI negative focal epilepsies. So there's actually this multi-center epilepsy lesion detection project, and they had this work published in 2022. And so they kind of developed this open source interpretable surface-based machine learning algorithm to automatically identify these focal cortical dysplasias. And they performed this retrospective MRI cohort of over 1,000 participants. Over 600 of them had focal cortical dysplasia related epilepsy, and they had 397 controls from 22 epilepsy centers from around the world. And so based on 33 surface-based features, they're called the MELD project. They trained and cross-validated a neural network on 50% of this total cohort, and then they tested the network on the remaining withheld 50% of the cohort, and they did this at 2 independent testing sites. And so across the entire withheld test cohort, after including the border zones around the lesions to account for uncertainty around the borders of manually delineated lesion marks, the sensitivity was about 67%. And then on a restricted gold standard subcohort of seizure-free patients with FCD type 2B, and those patients who had T1 and fluid attenuated inversion recovery MRI data, that the MELD FCD surface-based algorithm, it actually had a sensitivity of 85% and specificity was 54%. So they actually had a high sensitivity value, and they had a large sample study. And actually, you can go on their the website, and they actually have this automatic classifier ready to run on any patients with suspected FCD. So there were 2 studies that trained. So this is a neural network. The forward neural network with surface-based features and obtained similar and modest sensitivity values of 73%. And then another study reported that flare signal intensity was actually the metric with the highest discriminatory value, followed by gray-white matter intensity, contrast, local cortical deformation, and cortical thickness were also important. So here, histopathological and genetic analysis may characterize FCDs into different types, potentially exhibiting certain features visible in MRI. So you can kind of see the cortical thickening, flare hyperintensity, transmantle sign, gray-white matter blurring, and abnormal gyration. But almost 1/3 of patients are deemed MRI negative. So studies based on structural MRI predominated with sensitivity values of 73 to 90%. And then there was one study that was based on metabolic images, and one actually that combined the structural MRI and then metabolic information, but it wasn't superior compared to the other ones. There were some papers that had used images as inputs to the neural networks. They reported higher performance, 77 to 90%, than the papers that relied on like, on, what did I mean to put here? On, I think, just, can't remember. Oh, I think the other ones that were kind of, I think there was just on like T2 flare alone. So the differences could have been influenced by the approach to the model evaluation. The accuracy also depended on how neuroimaging is processed for feature extraction. And in the works based on metrics approach, authors agreed that gray-white matter, intensity, contrast, local cortical deformation, and cortical thickness were the most sensitive metrics. And so some of these were limited because they didn't have a ground truth to label the lesion, and not all the authors really detailed how they calculated the overlap between the lesion detected by the deep learning model and the reference lesion. So for robust validation, histopathological data and post-surgical evaluation, including MRI, should be available to assess how well the automated methods actually are correctly identifying these lesion edges. But one merit was it was able to identify lesions in MRI classified as negative by visual inspection. But there was a good amount of false positive rates. So here I had kind of another table reviewing a few published studies again. Just to kind of go over, so FF, and then so that's the feed-forward neural network. You had the convolutional neural network, and then relational network, and that just means that it can infer relations. And so you had 2 similar studies that were based on unsupervised learning, and then trained convolutional neural network with the DWI streamline coordinates to locate functionally important white matter pathways during pre-surgical evaluation. The gold standard for finding these eloquent areas was electrical stimulation mapping. And so then you have this at the top, you had reported accuracy of 73 to 100% for detecting eloquent functions, so motor, auditory, visual, and language within kind of this spatial resolution. Then you kind of had as well, so this next one, 68, that particular study that reported an accuracy within the range of 86 to 100%. And they actually sampled 89 children with focal epilepsy. And they also evaluated whether such classification predicted likelihood of seizure freedom, functional deficits, and language ability after surgery. The results showed high accuracy in prediction of functional deficit. And so 98% for motor deficit, 89 for language deficit, and 91 for visual deficit. They also had significant correlation between the neural network determined tract volume with post-surgery changes in language ability as well. So you had the three other works that were here. And so those proposed deep learning models predict expressive and receptive language scores of children with epilepsy from DWI. And these authors trained a neural network on learning nonlinear relationships between structural connectivity, so the input, and the language score, which was the output. And to evaluate predictive capacity of the model, they used Pearson correlation coefficient and mean absolute error between the actual language scores and those predicted by the neural network. So then you had kind of this second study, this one here. So they combined two different architectures. They used a, let's see, which, the CNN with the relational network. And in that work, they input the network consisted only of connectivity values between expressive and receptive regions delineated on the psychometric driven DWI. And so they actually reported higher correlation values and mean absolute and lower mean absolute error compared to the prior study for expressive language and for receptive language. Okay. So these studies have actually shown potentials for potential of tractography-based deep learning models for surgical planning and for the prediction of post-surgical outcomes in patients in drug-resistant epilepsy. Some of the papers supported that the hypothesis that tractography-based neural networks have potential as a biomarker of language function. And so that opens the possibility to optimize and individualize therapeutic interventions for the treatment of language dysfunction in children with epilepsy. So investigations are a good starting point for predictive tools and a way to better our understanding of epilepsy as a network pathology. So the studies based on tractography could guarantee accurate and individualized prediction of the response to the therapy, and it could lead to standardization of possible connectivity biomarkers when discriminating epileptogenic networks from non-epileptogenic ones. And so it did have a few challenges. So they center on collecting and assessing patient data. If a person is deemed MRI negative, but clinical evaluation is indicative of a focal cortical dysplasia, can the AI still pinpoint the FCD on the MRI? Potentially abnormal regions on the MRI? Can the AI evaluate if it's pathology? And then FCD detection consists of the input data and the ground truth. Input data, usually the MRI data, but potentially other imaging or clinical information. They can vary significantly across studies. The MRI data can stem from different scanners with varying field strengths and may consist of different imaging modalities like T1 and FLAIR sequences. The choice of MRI sequence can be significant. And in most studies, the FCDs, they're labeled manually in all three dimensions. The ground truth of the lesion mass, they have different levels of certainty. And gold standard for validation of focal cortical dysplasia case is histopathological confirmation, which is only possible after the surgery has already been completed. So kind of just going through the types of SCD. So type 1 MRI findings include some mild hyperintensities in white matter, T2 flare images, or cortical atrophy, or you can have no visible MRI abnormalities. Type 2A, so you have MRI findings with abnormal focal cortical patterns of cell side gyri, cortical dimpling, mild cortical thickening, and blurring of the gray-white matter. And then you have mild hyperintensities in T2 and flare signal in the subcortical and deep white matter. Then you have type 2B, and you have these with balloon cells, and they include deep sulci, abnormal cortical gyration, and hyperintense T2 and flare signal in subcortical and white matter. And then sometimes they'll have this like wedge shape that extends to the ventricle surface, which is called the transmantle sign, which I showed a picture of earlier. So you have these type 3 lesions as well, and they share typical features. So you have mild malformations of cortical development, and these malformations with oligodendroglial hyperplasia as well. And they can have this blurring of gray-white matter interface and flare hyperintensities in kids. And then in adults, the MRI findings include changes of gyri and sulci morphology with either mild or no cortical subcortical changes on flare signal, and blurring of gray-white matter interface, and then cortical thickening as well. So the type 1 FCDs are challenging to correctly diagnose. The diagnosis of type 2 is relatively straightforward due to its characteristics, but you can still have some sampling issues and misclassification, whether it's a type 2B or a type 2A. And then the balloon cells are primarily in the white matter adjacent to the abnormal cortex in the type 2B. And because the resection of the subcortical hyperintense zone in type 2B is not essential for seizure freedom, the pathology can miss these balloon cells just because of their location. And so you have new molecular, genetic, and epigenetic characterizations of these FCD biopsies, and they can improve diagnostic accuracy and be integrated into a multi-layer diagnostic scheme that can kind of give more fine-grained classifications. Some limitations of kind of this neuropathological categorization, so they especially when you're kind of describing a data set and defining a ground truth. So like different imaging sequences, the proportion of the various FCD types and imaging features within a data set, they can kind of impact the model evaluation. So kind of the techniques used for this automatic FCD detection use a processing pipeline. What that is consists of 3 parts. So it does pre-processing, the AI algorithm, and then the post-processing. So here I have an example kind of like prediction. So you have 2 subjects with confirmed FCD generated by 3 recent works that were kind of discussed in this review from Epilepsy. And although each produce an output for the whole brain, the predictions differ. So the models for image processing falls into one of the 3 major categories of computer vision, classification, object detection, and image segmentation. So 2 like medical experts determined the ground truth lesion mark, so that's the green outline, and independently using available imaging sequences and pre and post op information, including histopathological confirmation. So you have these 2 other pipelines here. This is kind of one we had kind of discussed before the MELD project. So they determined whether the algorithm actually has found a lesion, and it wasn't the finding was actually significant. But just the current widely used criterion of counting even just like a single voxel as an overlap as a success, it leads to all of the models finding throughout all of the example, they find an overlap. But the retrospective predictions are pretty significant. They differ. So the predicted voxel amount, they have, let's see. So they vary in values for evaluation metrics. So like the true positive rate, the positive predictive value, and the dice coefficient, those are all kind of a little bit significantly different depending on which algorithm was used. And so classification. So classification is a model predicts what the input data is. Its output value is between a 0 and a 1, and similar to the probability for the input data belonging to a particular class. So in particular for FCD detection, possible classes are either lesional or not lesional. And the input data ranges from raw MRI data to morphometric maps or surface features that they can use. Anomaly detection or outlier detection is a binary classification, and it involves comparing test data with assumption of what is normal. And so this assumption can stem from a database of healthy subjects, and more recent approaches learn from healthy subjects through deep learning architectures to estimate healthy anatomical variability and to identify lesions as kind of outliers from this like healthy distribution. So object detection, which I briefly mentioned earlier, is a model that decides what and where an object is in the input image. So where like this FCD lesion is. So the outputs consist of kind of this coarse localization information in the form of a center point, and then it kind of this bounding box in addition to classification information. Has been successfully applied to other areas of medical imaging processing like skin cancer, breast cancer, and brain tumor segmentation, but it hasn't actually been used for FCD detection just yet. And then you have segmentation. Segmentation also predicts what the input image is, but in contrast to classification, segmentation produces a label for every input voxel. And the output then has the same dimensions as the input data, whereas for classification, the outcome is only a single value for the entire input. And there's been some like published approaches for segmentation based on a type of model that's widely applied in medical imaging. And this is kind of the one that could be the most important for planning surgeries, where one goal is to identify and remove as much lesional cortex as accurately as possible. So this is just kind of what I discussed a little bit earlier. And so a model's performance is assessed with different evaluation metrics depending on the goal, classification, object detection, or segmentation. And then sensitivity, specificity, and likelihood ratios are typical choices for classification tasks. The threshold for translating predictions to class labels, they can alter the model's performance on downstream tasks that they do, such as patient level diagnosis. And the same metrics apply to object detection after matching objects in ground truth clusters. The metrics also help assess the segmentation quality and allow for model evaluation on the level of its output. So it's limited because a lot of the papers or works, they only use T1 sequences. Sometimes they added flare sequences. The flare sequences could benefit from FCD detection because they could exhibit only kind of local hyperintensities, so 50 to 70% of type 2 cases, but it could be less helpful for kind of these harder to detect type 1 FCDs were less than 20% were associated with any flare changes. In clinical practice, localizing information is usually not communicated by bounding boxes or segmentation apps. So you have to manually label the MRIs to get this ground truth. And the object detection kind of offers this trade-off between classification and localization information that requires less accurate manual labeling. But the lesions don't really fit very well into this rectangular bounding box just because of the shape of the cerebral cortex. And segmentation approaches provide most lesion-specific output and naturally incorporate spatial context. The anomaly detection requires kind of the least manual labeling, but the anomalies might not be just pathology specific enough. And then, so patient-level diagnosis is the ultimate goal for clinical SCD detection. The question is how low-level predictions, like, for example, some voxels classified to be lesional relate to actual decision-making on a patient level. Answering the question, does someone have focal cortical dysplasia? Current works often accept even just a single voxel or vertex level true positive as a true positive on the patient level. For control cases, even a single false positive prediction counted as a false positive diagnosis. And it kind of remains to be seen how these lower level, like voxel or vertex or lesion level or patient level predictions impact clinical decision making. And one study did note that there was a patient level detection rate of 93%, and they had an average of 6 false positive clusters per patient. So confidentiality of medical data is another significant hurdle. Few of these works actually made the used data accessible. And regarding kind of these false positives, experts usually know about evidence from other modalities like semiology, EEG, or PET. And it was rare for medical experts to find false positive lesions in healthy controls. So comparison to healthy control subjects was also biased, as the scenario doesn't really arise in a clinical setting. And recent studies also had kind of rates of incident findings of brain abnormalities, but it didn't really quantify, but nowhere has quantified whether this detection performance on healthy controls and or how likely medical experts. So essentially, they weren't able to. They didn't perform enough testing on how likely medical experts are going to find these different brain regions as lesional and incidental kind of findings on MRI. And so you had these automated approaches parallel to standard visual MRI analysis. They may enhance clinicians' confidence in evaluating these focal cortical dysplasias. Algorithms, they should be evaluated prospectively based on the impact on the quality adjusted of life years of people with epilepsy, the improved surgical rate outcomes, more admissions to surgery, faster diagnosis, or fewer other diagnostic procedures. All would be signs of a positive effect. The kind of just last thing briefly I wanted to talk about was seizure forecasting, which I thought was really interesting. So unpredictability of seizures is one of the most limiting aspects of epilepsy. Deep learning approaches is attractive for seizure forecasting just because of identifying features in ultra long term time series data and the heterogeneity in time series data characteristics between all of the different patients. And deep learning has a high power, and these algorithms are trained on very large data sets, and they have increasing capability to forecast seizures with non-invasive sampling devices. And so the training, testing, and validating forecasting algorithm, they require a really long duration of recordings with an adequate number of seizures. Concurrent video or EEG validation of seizures in an ambulatory setting over months to years is just logistically difficult, and it's not possible using conventional in-hospital monitoring methods. And self-reported seizure diaries are the most accessible validation, but they kind of have this poor reliability of just in their nature. So seizure prediction with wearable devices was investigated in this cohort of in-hospital patients using cross-patient deep learning algorithm recorded on these Empatica E4 devices. I think they're discontinued now because they're coming out with a new one called Embrace Plus, but there are lots of like similar wearable devices. But I'm just gonna discuss this one particular study. So they had data sets including multi-day recordings from 69 epilepsy patients, 28 of which were female. They had a duration of over 2,000 hours of data and recorded 452 seizures. They achieved better than chance prediction in about 43% of patients with no difference in performance between generalized and focal seizure types. So they also showed that the seizure occurrence can be modeled as circadian or multi-day patterns of seizure risk over long periods, and the pattern could be used to forecast seizures. Using a mobile device, like a seizure diary app, seizure forecasts calculated based on circadian multi-day seizure cycles, using the data from about 50 people who were using the application, and they produced accurate forecasts for about half of the cohort. Long-term cycles of seizure risk offer complementary information to direct forecasting of seizures. Signals from wearable fitness trackers have been shown to have some value in identifying these circadian and multi-day cycles of seizure risk. So patients who do have drug-resistant epilepsy and were treated with RNS as part of their clinical care, so they were recruited into the study. The patients were instructed to wear a wristband, and then they were charging the second band, and then they synchronized the data via tablet every day. And so the E4 device, they recorded physiological data, included accelerometry, blood volume pulse, and that was measured by photoplasmography, oh my God, I can't say this word, photoplasmography, and electrodermal data. And so essentially that all that is an optical technique, and it detects volumetric changes as well in the blood circulation. And then temperature as well. So minimum of about 6 months of recorded wearable and concurrent intracranial EEG data was required for inclusion in this particular study. So they had these 1 hour pre-ictal data epochs were defined with a setback of 15 minutes before the actual seizure onset was recorded by the EEG device. So the lead seizures were defined as seizures separated from preceding seizures by at least 4 hours, and they excluded the seizure clusters not to artificially inflate any of the results. So here's kind of what that kind of study looked like. So you had this, in the first figure, you have data kind of flow diagram of the ambulatory data recorded by the wearable sensor. So that was just kind of transferred via cloud storage and then analyzed using deep learning. The ambulatory data recorded using the wristbands was uploaded regularly to the cloud storage by the patients and then downloaded by the staff, and then patients uploaded RNS data as part of just like their routine clinical care, and that's when the EEG clips were reviewed. And the second one is just kind of the architecture of the machine learning classifier with all the different layers they use, the hidden nodes, and the output layer they use to generate the classification output. So this kind of third figure just shows like the raw wearable data, and it's just plotted everything kind of described before from, and then you kind of see this the green area, that's a pre-ictal segment from 75 to 50 minutes before the approximate seizure time. And then I just have, so the five of the 6 patients analyzed achieved seizure forecast significantly more accurately than chance predictor, with mean area under the curve of 0.8 compared to 0.48 using randomized seizure times. And the seizure alerts occurred about 33 minutes before the EEG recorded onset in this cohort. And then this is just here how you can see the influence of each signal and its related features on the classifier performance. The algorithm was trained and tested 5 times with each signal removed, and the average area under the curve difference from the full result was calculated. And times a day was actually the most consistently important across all patients, but most patients also showed high reliance on accelerometry and electrodermal activity and temperature as well. So, I mean, it was limited. Further limitation of like ambulatory data collection was inability to record seizure semiology with EEG correlation. So they didn't use video data. So it's possible that accounting for seizure semiology and training data could improve its accuracy, in particular if the seizure had any sort of clinical manifestations. The data quality is also a challenge in ambulatory in-home studies due to artifact motion, if the device didn't really fit very well. And the accuracy of forecasts required to be clinically useful just varies on the intended use of the forecast. So patients who already have neuromodulation, and if you just temporarily increase the stimulation due to false alarms, there's not really any harm in doing that. Multiple alarms daily may be acceptable. For administration of fast-acting medications, false alarms could also be acceptable if the overall medication dose is better targeted towards periods of this like high seizure risk. Probably less acceptable in caregiver alert use cases where the caregiver fatigue and annoyance could lead to some discontinuation of the devices. So clinicians can only see a small portion of patients covered by extensive healthcare system. So they only know, your patient outcomes, those reported by colleagues and those reported in clinical literature. AI can potentially draw upon data from entire healthcare systems to derive diagnostic and prognostic information that can fill gaps in experience or serve as reminders before decision making. AI, I mean, just does have this kind of black box nature. And even though there have been a few publications that have shown superiority of these deep learning algorithms over visual evaluation by experts, the reliability of predictions based on features that can't be understood is difficult to accept. There's also too much variability currently in the methodologies that have been implemented, which can give rise to a diversity of results that are difficult to integrate. That also can undermine the reliability and acceptance and incorporation of using these sort of tools in our clinic. The method should be more standardized and validated to achieve better, reliable, transparent predictions that are highly precise before integrating them into use our use in clinics. Complete characterization of patients is crucial. Some of the applications addressed in review required histopathological confirmation and post-surgical evaluations, which is also not possible in all of the clinical settings. And AI hasn't fundamentally changed the way we monitor or really care for epilepsy patients. Still a long way to go in the way that AI tools can be translated and generate real world life-changing data that will impact epilepsy patients. Consequences of inadequate training and human error can lead to misinterpretation and incorrect diagnoses, but AI can become efficient and can be efficient and practical tools to better interpret, access, and understand clinical information and narrow differential diagnoses in simple and complex cases. Reliable seizure forecasting can let people with epilepsy modify their activities, or take a fast-acting medication or increase neuromodulation therapy to prevent or manage impending seizures. So thank you. This was something I was, I guess, very new to reading about. I feel like we already use AI in stroke. I feel pretty regularly in whenever we were in the hospital. I feel like it's not something we use too much in epilepsy yet, but I hope it makes you guys a little bit more interested in reading up about how AI works in your particular areas of interest, and I think there's still a long way to go in the way that we use deep learning algorithms, but I think there's a lot of very interesting cases and applications in the future. Does anyone have any questions? I know I ran kind of long. I tried to squish everything into less slides. I probably could have done like twice as many slides. Yes.
Thank you for your comprehensive review. Can computers provide a better or a competent interpretation of a routine?
I think kind of the spike detection and going over data that was, I think it could not replace a physician. I think it would just be used as a tool, essentially, either showing abnormalities like abnormal spikes or areas that are seizures for the clinician to review. I think it's still a work in progress, so I don't think that there's anything that could replace or do it as well as a physician just yet, but I think at some point it will be able to.
Right, in all these comparisons of the computer and humans, we're always assuming the human is like the best there can be.
Right.
We should consider that all doctors, half of all doctors are below the mean. In some places, the person interpreting the EEG did not do a fellowship in EEG.
That's
Maybe correct. They learned how to read EEGs 30 years ago. So that the comparison should be between the new systems and an average.
That's exactly right. I think it's exactly, it can be used as a tool to kind of bridge any sort of gaps in knowledge and assist in diagnosing, seizures, or be used to kind of differentiate cases that are perhaps just a little bit more difficult. Anyone else have any questions? Yep.
I think you kind of mentioned that there's two forms of the neural networks. One was kind of like there's not as much feedback back into the.
Yeah, and there's one that has like backwards propagation as well.
Is that kind of the role you see as a physician playing? It's like kind of analyzing what the prediction the AI is making and either giving it the carrot or the rod and try to help you correct the algorithm moving forward.
I kind of just wanted to go over how these algorithms work because a lot of these studies that are published use all of this like technical data. So I kind of wanted to give everyone an idea of what definitions and all of that. I don't think the role of the physician will be necessarily to kind of like correct it. I think once there's like proper algorithms in place that are used, just using essentially these outcomes and using that as like to assist you in making your diagnosis or differentiating between like a focal lesion versus not, a lesion, something that's lesional versus not lesional, versus if you get a, like a seizure that they show you, is this a seizure, is this not a seizure, kind of either saving you time or kind of helping you decide whether something is pathological or not. All right. Thanks, guys. Oh, okay.
And I took some picture.
Oh,
I'll
okay.
send it to you. Can you send me your?
Okay, yeah, of course. I can send that to you.